If you don't know me, I'm Emma Whitlow, the Practice Liaison Officer for Notts LMC. I'm joined today by Lucy Cassidy, Head of Liaison. The first part of the session will be from Rachel Dean, Rachel Chatwin from the Behavioural and Emotional Mental Health team at Notts City Council. And after that, Lucy will be joining just to go through a few bits from us at the LMC. So Rachel, I'll hand over to you if that's okay.
Emma, do you want us to share the slides? We can do.
Whatever is easier for yourself.
We'll share. Just tell us when you can see them.
Yeah, perfect.
Okay. Thank you for having us, everybody. We really appreciate it. We're hoping to give a few updates and hopefully some information about the team that the GP practices will find useful, and hopefully some things that will support you guys on the front line. So our team is the starting point for referrals where there are concerns or queries regarding possible autism or ADHD. Although we are Nottingham City Council that the team is that works from, we are commissioned by the ICB. So we were directly awarded the contract from the 1st of April 2020, just as COVID came into play, which was quite interesting. And we were re-awarded the contract until the 31st of March next year. So historically, we've been a very, very small team, but there are currently 12 of us, and I am doing some ongoing recruitment as well. And this is because of the demand on services, and capacity is really outstripped by demand. So in terms of our role, we are a non-clinical team, so we are the starting point and we collect all of the information to consider any ongoing assessment by community paediatrics. It's really important with that in mind that we gather information from home and from school, because as you know, that informs the assessments. But alongside that, we do offer the New Forest parenting programme. We try and take out the word parenting though, because it's very specialist, and it is for children or parents of children where there are needs that may be arising from ADHD. It is a strength-based programme, and it is the first line of care in regards to ADHD, and that is an expectation by community paediatrics. We also offer the Signet programme, which is for children that have been diagnosed with autism, and that programme is for parents of children to 5 up to the age of 18. And I think the next thing, which I think hopefully is GPs that you might find the most beneficial for yourself and your frontline staff, is that we now offer support clinics. So what we don't want is, we don't want families to not come to you as a GP because there may be needs arising from that child or concerns from the parent that need that GP insight and that clinical assessment up front. So if there are, as you know, concerns around PICA, global developmental delay, ARFID, any regression in a child's development in any form, that may require you as a GP to consider a direct referral to community paediatrics. So what we don't want is, we don't want families not to come to the GP, but if following your assessment you feel that it's not an urgent requirement for a referral to community paediatrics, you may want to signpost the family to come and have a meet one of our practitioners to go through the process of what their concerns are, whether that needs a referral to the pathway, or actually if there are expectations around a graduated response, i.e. an evidence-based programme that may be from our early help colleagues. We're quite happy to have that, or we want to have that conversation with the families, because I think then we can be very clear as to what needs to happen, steps that need to be taken, and hopefully guide them through the pathway.
I just wanted to mention, because I can see a comment in the inbox, is that what we're talking about today is we're the city service.
Yeah.
So we are different from the neurodevelopmental team in the county, and we are the service to refer to when the child is registered with us, a GP that falls within the Nottingham City boundary. So we are working closely with the county, so that if children's need to be transferred between us, we have got those existing relationships to do that. But everything we're talking about here today is the city pathway.
Okay.
In terms of booking onto those support clinics, we encourage families to give us a call or an email. So please feel free to share our contact details. We do support clinics with the family support workers, but our screening advisors also do offer some clinics for parents around actually physically making that referral. If individuals need that support due to literacy levels or a range of things.
And again, for your frontline practice staff, if parents are calling wanting updates, please encourage them to come directly to us. We know how busy primary care services are, so we are more than happy for, rather than your frontline staff to be the go-between, please encourage the family to call us or email us, and we will give them those updates.
We are very responsive on emails and calls.
We try to clear our inbox at the end of every day. So at a maximum, a family should be waiting 48 hours for a response from the team. And what we would also, there was something just went out of my mind, sorry. When we receive a referral, we also now send an acknowledgement letter to the family and with wait times, and that does actually give a process map as well of the pathway, but also times around our wait time scales, so which are currently 10 months, but I'll come on to that as well. So as a
apologies,
sorry, as a team, there are two services. So the team often gets referred to as BEMS, and we are not BEMS because we're not mental health. So we do have our targeted CAMS colleagues, which also sit within Nottingham City Council. So any needs that are identified around emotional and mental health needs, or any consideration around primary support needs, they need to go to our targeted CAMS colleagues. So your anxiety, depression, and self-harming and suicidal thoughts. Our team is purely for the neurodevelopmental elements, so the autism and the ADHD. We are, though, going to be changing the name of the team because the name of the team does not work. We inherited this name, and it implies we're a generic behavioural and emotional health team. We're not. We're quite a special. We are a specialist pathway. So we will be changing our name to the Neurodevelopmental Pathway and Support Team, Nottingham City, because we need to detail that it is city GPs only.
And we'll make sure that that's communicated with the current email addresses we have for you all.
Yeah. I'm just conscious of time, that's why I'm trying to go through really quickly. So at the point of referral, key information for us is that all mandatory fields are completed. We changed our process in September 22 to a significantly longer form. However, that was to reduce timeframes within the service. So we know that if we receive a fully completed referral form, that we can improve timescales by between 3 and 6 months for that young person, and it stops us going backwards and forwards for information. We also know that even something like an NHS number, if we insist on that being completed at the point or given to us at the point of referral, it can increase our assessment capacity by up to 17 hours a month. It reduces the correspondence that we have to have with GP practices to ask for that information, and it also reduces the risk of duplicated young people, because we have some people that go by preferred names rather than birth or given names. So we do require holistic and informative referral, and I guess this is where for GPs there is a real balance between what you're able to provide from the time that you have in clinics and actually what we require to complete a non-clinical assessment. So we do need that information from home and school because it's very pertinent, and it has to be a reflective assessment across environments. So we do ask for that information. Now, we don't expect GPs to have that, hence why we've created the support clinics, but also if the referral forms can be given to parents, then for them to either seek further support from us or from school, it will improve the timescales further down the line. We need evidence as to how the child's identified needs are being supported. So again, we would expect school, if there are identified needs in the education system, that they will have put in place support and plans. So around the assess, plan, do, review process and routes to inclusion that's in Nottingham City. We also require children's learning and developmental needs and levels, because a lot of children that are referred to the pathway that may be needs of or highlighted needs of autism, it may in fact be potentially global developmental delay or an intellectual disability. Any health or developmental diagnoses, so that is really important. Any current community paediatrics involvement, and any family history of neurodivergence, or if they are currently being assessed. We do have certain criteria that we will accelerate children based upon, and if immediate siblings or parents have diagnoses, then we do aim to review those a lot quicker.
And if we have all of that information, obviously a child can move through our part of that pathway a lot quicker, and it enables us to make those real informed decisions. I can see that there are some questions about whether we mirror the pathway in county, and our teams do serve the same purpose, don't they, in terms of our roles?
Yeah, our roles are very much the same, but the way we go about things are different, because we have access to different information that they have access to. Okay. So I think this next slide is really important, or is probably one of the most informative ones for you as GPs and practitioners. So within 2 weeks, I mean, it has been 3 weeks lately, if I'm going to be really open and honest, because of the volume of referrals that we receive. I'll come on to some stats, but it's well over 200 a month. Within 2 weeks, we will review the referral and assess if we can accept or if we cannot accept the referral. it's not based on the needs of the child. So what's really the requesting an assessment, it's usually based on mandatory information being missing, i.e. the name of the parent, a telephone number, and even the if the privacy statement has been shared, we can't go any further without that. We can't share any ongoing information if that's not highlighted as being received and understood by the parent. So we do have 2 referrals. We have the workshop referral form and also the standard longer referral form. The workshop one was created for specifically around the Signet and for the New Forest programme as quicker ways to refer to those. Then we have our standard referral form. We then, once we've looked at and we can accept the referral, we do have a standard priority waiting list and a high priority waiting list. The standard priority waiting list is currently a minimum of 10 months. So if a referral was received today, we would not be in a position to be able to physically review and allocate that to a practitioner to review for 10 months. So that's why it's so important that support is being put in place for that child's identified needs within the home and the school environment, and is not diagnostic led. We do, however, have a high priority waiting list where we aim to review all of these referrals within 12 weeks. On average, they're about 10% of our waiting, children waiting. So I think when I looked on Friday, there was 690-ish children in the waiting for the general review, and there was around 70 in the high priority. So what goes into the high priority is referrals from speech and language, referrals where the child has an open child protection or a child in need plan, with the idea that we are informing and understanding environmental needs that may be pertaining to that child. We also 16-year-olds because of the wait times in adult services. So adult services, there's a minimum of 3 years in Nottingham City for an assessment. So we do have an arrangement with adult services so that if a young person is up to the age of 17 years and 10 months, they can be referred to this pathway. Beyond that, it has to go to adult services. We will accelerate them now with a view that we will meet that young person. If we assess that they have needs and behaviours that may be indicative of autism or ADHD, we will then bundle that information together as we would have done for community paediatrics, but we will send it directly to adult services, and they will honour the referral date that the young person was referred to us, and that is the same for the county. So that is in place in the county. That's what commissioners have put into place. So I think that's a really good and positive outcome for young people at that transition stage.
We also prioritise reviewing referrals where the parents have already completed the New Forest parenting programme. So if following a period of that watchful waiting to embed those strategies learnt on that course, a further referral is made to us, we prioritise reviewing those.
Yeah, and we have our timescales of that 10 months have stretched, so it's a minimum of 10 months. Again, in the spirit of being very open and honest, we're at 11, aren't we? We've got 6 children to review from June last year, and then we enter July, which is horrendous because we get 4 times more referrals from schools in July than any other time of the year. That we have accelerated all year 6s. So what we did is we picked up any year 6s that in primary school year 6 that were referred to the pathway before the start of the Easter holidays. with a view that we will review them, which we have. And we've now booked in all school observations for those young people, and we've increased our capacity for, well, we've increased our school observations to be able to complete those by the time that they finish school, because we know that transition points are particularly a particular worry for parents and for schools. So we've done that in the best interest of children, and we've had good feedback on that, so we're pleased about that. So once we allocate to a practitioner, we do a very, very robust assessment. Because we are part of Nottingham City Council, we do a very holistic assessment of that young person. So we have access to all child protection, child in need, basically all social care records if the child is a Nottingham City child. This is where the postcodes get a little bit confused. So the referral comes to us if it's a Nottingham City GP, but if they reside in the county, we will not be able to see their social care records, but we will if they're a Nottingham City child. So we accelerate any children that are on an active statutory plan, but we can see all historic information. We also look over to our CAMS, targeted CAMS and MHST colleagues as well. So that's the mental health support team. And if we can see that they've got open assessments or they're completing a programme of care with that young person, then we will consult with them and we may join their assessments as well, again, to reduce the need for duplication. So at the end of our assessment, we will can make a multitude of recommendations. It may be an evidence-based programme, particularly around needs around ADHD. It may be a discussion with community paediatrics. So we meet with community paediatrics usually every fortnight. We only have 2 hours. So within that 2 hours, we usually discuss between 20 to 25 young people. So we have to be really, really smart with our analysis, our formulation, and what we present.
Sure, we've got a wide range of information from those people involved.
There will be times when we do not progress along the pathway, and we will signpost to alternative services such as our early help colleagues, or it may be specialist services such as Amara, or it may be additional information is required. So we haven't got enough information from the referral, but something has sparked our interest, and we'll go out and get a further range of additional information or specific information. What we're also doing now as well is when we allocate to a practitioner, we're making contact with that family, because we know that things can significantly change within 10 months. So we are asking for updates.
And the additional information can include us completing face-to-face assessments. So we complete, particularly for primary age children, we'll do a quite long school observation. So we'll go into school, do an observation of that child at lesson, during their social interactions at playtime, and also have a one-to-one kind of play-based session with them. And for older young people, usually secondary age young people, we meet with them face to face and kind of explore their wishes, their feelings, and complete observations that way. And
we'll also discuss and link with professionals, i.e. our CAMS colleagues, but we also have a linked clinical psychologist with the team now. So there are, particularly where there are significant needs or backgrounds of trauma, attachment, adverse childhood experiences, let's just say, it doesn't mean the child can have all of those things and still be neurodiverse. it'll just take a lot longer to unpick all of that. So we will seek consultation with clinical psychology. We will seek consultation with community paediatrics if appropriate outside of the fortnightly meetings. And we also attend something called a complex case meeting where myself and Rachel are present, community CAMS, targeted CAMS, community paediatrics, because the child has got such high presenting levels of need. But usually particularly with the mental health, if the primary needs are mental health, there will be the expectation that the programme of care is completed by our CAMS colleagues, and it may be appropriate for any neurodevelopmental assessment to remain in the CAMS area of expertise, again, to reduce duplication.
Sorry, just referencing something that's been put in the chat. So any child that is with a City GP, it doesn't matter where they live, if they have a Nottingham City GP, we're the referral pathway.
Yeah. So it's irrelevant. So when I worked in social care as such, in child protection, sometimes we would ask people, what colour are your bins, to determine what, you know, depending on what side of the street they would fall within the county, fall within the in the city. We do have something called Nomad, which we look at, which determines
a mapping.
It's like a mapping tool that determines the authority. So it would tell us, so if I put in one postcode, it might say it's the house is in Gedling Borough, but it wouldn't matter if the so Victoria and Mapley is a really good example. Victoria and Mapley GP practice, we go on the Victoria, so then Mapley is a satellite, and if you looked on the system, it would fall within the county boundary, but it's not, it's Victoria and Mapley, so it's all city.
So even if they lived in Doncaster,
yeah,
and they had a Nottingham City GP, it would still be us. It just means that we can't access records like we can if they reside in Nottingham City. But that's up to us to seek that information out in conjunction with the family.
There's another caveat, or a cohort of young people, which are children that are looked after. If they are open to the CLA, Children Looked After CAMS team, then they can have a direct consultation with Dr. Amy Taylor, who's a consultant community paediatrician, because they can also complete neurodevelopmental assessments, but with her support. So these are just a few stats in terms of the service. So when the service was directly awarded to Nottingham City Council in 2020, we expected we were told to expect between 60 and 80 referrals a month. That is not what's happened. So in 2021-22, yeah, you can see the numbers. I don't need to read them out to you. But at that time, we probably received around 60 to 70 referrals from GPs per month. It's now significantly lower, around 20 to 30. But we feel that often the information, because of the variety of information we require, we actually know that it's that school information and home information is really important. So we anticipated that might happen with the change in the referral form.
And I think what we're seeing, this obviously went up until sort of end of March 2024. What we've seen in the months after that, in the couple of months after that, is referrals are only increasing. They're not decreasing. So we anticipate that this year's numbers are going to be much higher than what's on the screen here.
Yeah, I'd expecting them to go probably up to between 260 to 275, I think, this year.
So yeah, the need is ever increasing.
Yeah. But with all of that in mind, we do very much the processes that we've got in place. We are increasing the number of children that we are reviewing within 12 weeks. So we're currently at 49%. We are recruiting as well. I just need to get some finance sign off, but hoping to increase our capacity further.
And that's our aim that we want to work towards, is
Yeah.
that all referrals are reviewed within those 12 weeks. But at the moment, that's not been a possibility. But you can see that our numbers that we are achieving that are increasing.
Yeah. And then in terms of referrals that are accepted by community paediatrics, it is on average 40 per month. So what you can see is there's a significant difference between the number of referrals that are made to us and what actually are accepted by community paediatrics. Hence why we are changing our name, because I think our team name has created a lot of chaos. And I think that that will help making it very clear that this is for the pathway once.
Absolutely. And as our team increases, we've got a bit more capacity in order to kind of do that outreach type task. So we're spending a lot of time at the moment talking to schools, talking to other teams that refer into us, and ultimately we will be talking a bit closer with parents and families as well, to make sure that the right message is out there about who we are and what we do, so that we get the right referrals at the right time.
And I think we're quite unique as a service that we do accept referrals from parents. A lot of other services to pathways such as ourselves will not accept a referral from a parent. It has to be from a professional. So a few misconceptions around the pathway is, I've already touched upon this, is that we're a generic therapeutic or behavioural support team. That is not our role. We're not a learning disability pathway, although we do recognise that there are often behaviours or needs pertaining to learning needs and autism. We don't provide ongoing one-to-one support and family intervention, so that would be the role of a targeted family support team. And we are not the attachment or trauma pathway. However, there isn't one. So hence why we have got the clinical psychology input as well. What we don't do is we try not to do it's not us. So we try to, if it's not us, we try and get the child to where they need to get to. We don't have access to external reporting systems. So we don't, for example, have access to System 1 or any health systems. And different referrers don't have different wait times, so it's based on the needs associated with that child, not who has referred it. So referred the child. So a GP referral, for example, is not looked at quicker than a referral from a parent, a referral from school. They're all looked at in exactly the same way.
Sorry, trying to reply to some things in the chat as well.
So just I think this is the last slide, but when we talk about parenting advice and support programs within Nottingham City, the two main teams that would support with that are our early help colleagues and the parenting team. So this is a list of programs, evidence-based programs that they provide. Nottingham City is one of the selected hub authorities. So we do have 4 hubs across the city. So there is Broxtowe, where we actually sit. There's the Meadows. There's, I want to say Mary Potter, but it's not. It's Fyson Green, isn't it? Health Centre. And then Southglade. So Southglade Access Centre. So we are an early intervention and hub city as well. So and that's where parents and carers can obtain a wealth of advice and support to access services that are free within Nottingham City. I think that I've tried to get through really quickly, Emma, and I'm hoping that's yeah, I think that was our last slide, wasn't it?
It was, yes.
You want to stop sharing? I know Rachel's been trying to do some responses in there, and then you're half looking at one thing and half looking at something else. And I know Rachel's been trying to answer a few questions in the chat.
And I think Andy Summers said that he wanted to pass on information about the county pathway.
Yeah, thank you both for sharing that, and thank you for answering the questions in the chat. Yeah, Andy, if you want to come in on the county side, that'd be great. Thank you.
Yes, thank you. So my interest in this is I'm the GP mental health lead for the mid-Nots PCNs, and we've been discussing CYP over the last year or two in our sort of operational group meetings with both commissioners and providers. And I suppose the key themes with this are that generally speaking nowadays, we don't feel there is that much role for a GP in referring to your team. And that others have a lot more time and a lot more information to actually do that. So we generally signpost parents to the Healthy Families team, who can then provide the sort of lower level support if they don't meet those thresholds to refer on to teams like yourself. The second point was, I was really pleased to see in your presentation about prioritising and looking at urgent pathways. And one of the things that we really need, which causes a lot of distress and difficulties in the system, is when children present with violence, whether it be things like hitting and punching siblings, pulling knives out of drawers. And I think we need a really clear pathway so that when the distressed parents pitch up at our door, we actually understand what that pathway is. At the moment, it feels like we sort of hand out a whole range of different sort of telephone numbers and signposting, and it just feels a bit disjointed. I think the other thing is that we've still got issues with CAMS, and I think for a long time, as in other areas, we'd like a single pathway that actually encompasses both behavioural and mental health problems. We still have patients sort of bouncing around the system, and it's whether they come to you or whether they go to CAMS. And to be frank, CAMS thresholds are so high that it's actually hard to get them to review anybody, really. And I suppose that the last thing is that I don't know if this is still the case, but I've argued for a long time that there are actually services such as yours should be doing direct referrals to community peds. There is no reason to involve the GP in that pathway because we actually literally just forward the information on. So I think we need to see a sort of more joined up pathway from the start and the end. Although it may feel like we're sort of washing our hands of the situation, it's because actually it's just not appropriate for our intervention. And even those children who have developmental issues, they're going to get picked up by the Healthy Families team anyway. So that's a sort of, in a nutshell, where we've got to from a county perspective. I'm not sure if that helps or not.
Yeah, it does, and I can give you a few updates so the county and the city do work very, very differently. We have access to our targeted CAMS colleagues and do joint assessments with them, which I think commissioners and the service manager in the NST service in the county are looking at how those interactions can improve, because I think you're right, Andy, that a lot of young people did bounce around. As Nottingham City, though, we are adamant that we do not want our children to be over-assessed. So we will pull reports off and we'll see, for example, a young person is going to see a CAMS colleague in 2 weeks' time. We will approach CAMS and we will say, we want to join your assessment. Can we join your assessment? Oh, yeah, okay, fine, brilliant. You know, wham, bam, that's good. We'll also move children. So if their primary presenting needs are mental health, targeted CAMS complete a programme of care with that young person. So guess what? They get to know them, they see them face to face. Brilliant. They make observations. If they feel as qualified practitioners that that child's presenting needs and mental health has been stabilized to a point, and actually there are now behaviors that may be indicative of neurodivergence, and actually the behaviors their mental health needs may be stemming from neurodevelopmental needs, then what they will do is they will slide those young people across to us. So I sit with the SPA specialist every 2 weeks, or Rachel does, and we will discuss those young people. They don't need to come back to my team. We'll pick up all the information, we'll put that together, and we will present to community paediatrics, so they do not go back to the beginning. There are some very, very complex young people within our communities, and they need a multi-agency approach to any decision making, and to work out if actually the assessment needs to be mental health primarily, or if it needs to be community paediatrics. But we have that at a higher level meeting. And in terms of your back to peds, the city and the county work differently. So we don't send once we've got all of our information, we sit with community paediatrics fortnightly and have those discussions and send those bundles through. In the city, we don't send that information back to GPs to send on to paediatrics. We have that direct conversation with peds. Now, I believe in the county, they are currently looking at a way that they can send things over to community paediatrics rather than it going back to the GPs. So I know that's high on their agenda as well, because what we're trying to do is, I guess, all the way through the pathway, we're trying to be smart. So, you know, I'm trying to always reduce what your frontline staff are doing. You know, so we put in place the generic GP consent, which has saved a huge amount of time. So we're just constantly trying to look at how we can streamline what we can do.
I'm conscious of the time, and you said up to 45 minutes. We're coming in at 44, Emma. Is there anything else that you want us to go over or touch on, or?
No, thank you for coming. I mean, I'll do a final call for any questions or comments for anyone. We'll share the link that you've put to the referral forms and presentation in our updates. Thank you for that.
I'll just say that Rachel's the team manager of the team, and I'm the senior practitioner. We're both called Rachel, which doesn't help, but we're very hands-on. So if any emails come into the team inbox, which I have shared in the chat, we often pick stuff up. So if there are any queries, we are more than happy to kind of answer those directly.
Brilliant. Thank you both. Thank you both for coming along today and sharing that information. I'm sure if we have any more questions for people after this, we'll come along to you and ask for some updates and feedback.
Brilliant.
Thank you for inviting us.
Thank you.
Take care.
Thank you very much.
Bye.
Okay, Lucy, straight over to yourself.
Thanks, Emma. Hi, everyone. Nice to see you all. For those of you who don't know me, my name is Lucy Cassidy. I'm Head of Liaison for Nottinghamshire LMC. I just wanted to come today to update a little bit about safe working and some of the projects that I'm working on behind the scenes to support general practice. So thank you to those of you that completed our survey that we did for the 24-27 strategy. We've seen all the feedback, and that feedback that you provided will be linking into what we do next in terms of who said we did. So Michael and James will be joining the committee, the Practice Weekly briefing next week, to update on more of the strategic aims for the LMC. But just so you're aware, to start with, our 24-27 strategic aims for the LMC are going to be 3 main ones. So no surprises, but see, reducing workload shift into general practice, safe working in general practice, and financial sustainability for general practice. So the area that I'm going to focus on today is safe working in general practice. So my role's changed slightly. So you've got Emma and Stu that are the lead colleagues for the on-the-ground liaison queries. So Emma covers City, Rushcliffe and Nottingham West, and Stu covers mid-knots. Emmy, you're going to have to remind me. Mid-knots, Bassett Law.
Yeah. And then the other part of South, so Gedling, Arnold.
Yeah, so I've taken a step back from the day-to-day liaison stuff, but still heavily involved kind of behind the scenes in trying to help general practice. So I wanted to talk about safe working. So many of you will have had a visit from us now. If you haven't, we're very happy to come out and meet with you. Some of you have had monthly visits from me where we've talked about how you can work differently, and I've seen real improvements in how you work in general practice. So just wanted to update on one of the projects that I've commissioned Steve Murdoch and Jason Gomez to update on. So you might remember April last year, we did our launch event for Safe Working. Krish Kasaranani, a GP partner in Sheffield, came to our event, and we had Claire Bannon from the GPC, or then GPC, there talking about how we can work differently in general practice. So the BMA, as you will have known, has some guidance for safe working in general practice, which I will pop in the chat now. And that's things that, that's advice that the BMA and guidance have put together, where you can work differently while still in line with your GMS contract. So obviously we never want you to breach your GMS contract, but we also want to encourage you to work differently, and that whole cliche saying of putting your own oxygen mask on first. You can't be everything to everyone, and at some point you have got to get off the hamster wheel and stop. So the BMA safe working guidance, as you know, suggests things like moving to 15-minute appointments. So hopefully most of you will know this by now, because we've been banging the drum for months and months and months, but there's nothing in the GP contract that says that you have to do 10-minute appointments. So this is just a historical thing that everyone's done. So if you wanted to, you could move to 15-minute appointments now. There's nothing in the contract that says that you can't. The guidance also suggests about moving away from the never-ending duty doctor triage with uncapped demand. And we really want to push the message of focusing on the quality of the appointment rather than the quantity. We know from the NHS England statements and headlines that GPs are busier than ever and seeing more and more and more. Demand is always going to be there. It's not going away. Our focus and priority is really to keep safe working in general practice and to keep you safe. So as you'll see from the BMA guidance, and most people laugh at us when we say it, but the BMA guidance does suggest 25 contacts a day, because we know about workload fatigue and decision fatigue. If you're constantly having to make decisions from patients, about patients, you know, the patients later in the day when you're tired, you haven't had a wee, you haven't had a drink, you haven't had a lunch break, that's not safe working. So the BMA guidance says that obviously practices should take urgent action to move towards safe consultation numbers. So excess demand should be signposted and directed to NHS 111, extended access hubs, or other providers. In the GMS contract and GP contract, it says an assessment of need. So that doesn't mean, that everything has to be seen by you. As I mentioned at the beginning, you can't be everything to everyone. It's about signposting patients to the appropriate service. Dr. Gowder, I'll take your question. So I've said here, when it comes to moving to 15 minutes, does this mean we see less patients or the same number we currently see? Well, it will mean that you see less. So if you're currently seeing 6 patients in an hour at 10 minutes, that's 6. If you move to 15, that's 4. But what we're really trying to encourage practices to do is focus on the quality of the appointment and really focusing on the management of that patient in front of you to hopefully stop them coming back in the first place. So it will mean that you see less, and it may mean that you see an increase in complaints to begin with. However, wouldn't you rather have a complaint about access rather than a complaint because you've made a serious error, because you've continued to see patients in an excessive amount, haven't had a lunch break, haven't had chance for a drink? So yeah, it will mean that you're potentially seeing less, but there's nothing in the GMS contract that says a set number of patients that you have to see. In the contract, it says about meeting the reasonable demands of your patients, and that's for you to decide as a practice. You hopefully will have seen the comms from the ICB about the modern general practice funding. So this is £13,500 per practice that can be claimed to move towards a modern general practice. So if you haven't applied for that already, I strongly encourage you to do that. And that's things that you can use to if you're thinking about wanting to work differently and making changes, there's funding available in the system, and we'd want to encourage as many practices as possible to claim for that. The reason I'm here today, though, is to mention a couple of projects, really. So some of you may have seen when Krish Kasarani came to the event in April last year, and one of the ways that he changed how his practice worked was to focus on chronic disease management and trying to move away from the on the day, on the demand, and never being able to say no to patients. So he did this in various ways, but one of the ways that he did it was through pathology automation. So if we think back to the BMA guidance of managing 25 contacts a day, which obviously seems laughable, if you think of how many tasks you have or how many blood results you have sitting in your inbox before you even come into clinic in the morning, I would imagine that it's way past 25. So before you've even seen a patient at 8:45, I imagine many of you have had to review X amount of blood results. So if you remember, Krish Kasarani had a tool that he'd built within System 1, which meant that normal blood results could all be auto-filed. So we're mirroring the work that Krish Kasarani's done through the LMC. So the reason we've been able to keep our levies frozen since 2010 is because we have commissions through the buying group, which is our for-profit arm of the LMC, our subsidiary company, the buying group. And through those commissions, we're using funding to be able to support general practice. And one of the projects that we funded is for Steve Murdoch, who you may know, who currently works for PICS, and Jason Gomez, who also works for PICS and in Rushcliffe, to help with the IT. So we're going to mirror the work that's happened with pathology automation, and they've already started on this. So we're going to invite them back at a sooner date to launch this, because this is a project that we're really, really excited about. So these are auto review rules that are built in System 1, which will mean that when System 1 is set up and built appropriately, all your normal pathology results, the stuff that you're currently having to look at and review that doesn't need any decision but just needs filing, will auto-file with the rules that we've built. So it's currently focusing on HbA1c and using these, but we do have scope to move to TFTs and vitamin D. Shaheen, it's not live yet. It's in the pilot phase at the moment. We're just testing it with 4 practices to make sure that the rules are right and that it's got clinical oversight before we launch this. But we're really, really excited with the project. We're then going to commission them to go one step further. So then with the abnormal results, we're going to get them to support with the building of rules, so that when you have an abnormal result, the system will be able to build so that it will be able to send the patients a text message to remind them what to do next. We hope that this will link in with the abnormal results that come and support with the chronic disease management. So I just briefly wanted to update on the pathology automation project. Many of you might not have seen me recently at Practice Weekly briefings, but it's one of the projects I'm working on behind the scenes, and just one of the small things that we're trying to do to help with the workload of general practice. I mentioned about the practice sustainability survey, so I'd really ask if you could encourage everyone in every practice to be able to do this. So I mentioned about the levies that come and the commissions that come from the buying group. The practice sustainability survey, we hope every practice to complete, that we get a snapshot of where practices are most in need. And the support from the LMC Safe Working Task Force, which I'll be leading, will be allocated in line with the funding. So we really need that data, and Emma's put that survey in there first. GP consultant twinning scheme has restarted. So I might have mentioned that we put a bid in for system development funding as part of the interface project to start GP consultant twinning. The first phase has opened with NUH. It's going well so far. Some of you that have signed up will have received a match for a consultant. I'd also like to invite colleagues to an event that we're hosting on Wednesday, the 3rd of July. So Dr. Manjeet Sharma is going to be the new medical director of NUH. She's going to be there on Wednesday, the 3rd of July at 6:30 at Notts County Football Ground. And this is a free event where we're trying to bring GPs and consultants together to talk about the interface, how we can work together, and the projects that are happening behind the scenes. So I'll put that link in the chat there now. Helen's David sits on our City Safe working group. She just mentioned about the 13,500 is based on the average 9,800 patients. And I think that's mostly what I wanted to update on, Emma, because I'm conscious of time. But yeah, so practice sustainability survey, the event that we're doing with NUH on the 3rd of July, which I will put in the chat now. Everyone is welcome to join us there, but tickets are limited, so it's a free event. Obviously, you've got the GPC Roadshow event next Wednesday. Emma, did you want to talk briefly about that, just to finally message that one? But please rest assured that we're trying to do as much as we can as possible behind the scenes to help with safe working. If you haven't had a visit from us, please do contact us and we'll get in touch.
So yeah, just quick, Lucy, there's some comments in there about the auto filing that I think might be good for you maybe to take away.
Yeah, sure, I can see those. I will happily come back. Steve, Murdoch and Jason are meeting with at 2 o'clock for an update on the project. They are meeting with NUH Pathology, and the plan will be also that we can roll this out to SFH. So they are having conversations with the pathology team at NUH about this. Yeah, can confirm that one.
Thank you. So yeah, just quickly about the GPC Roadshow on the 12th of June. I've put the booking link in there. We've got Dr. David Wrigley and Dr. Samira Anand from the Deputy GPC England chairs coming along. They're going to be talking about the upcoming ballot, what actions practices can take. Networking with colleagues, is going to be a Q&A session there. It should be a really positive event. I mean, there's lots of questions about what practices can and can't do in regards to the contract changes. They'll have all the answers essentially about what action can be taken without breaching contracts and going forward. So please do, it'd be great to see someone from every practice there if possible. If you've got any questions, please do get in touch, but the link is there to book into. Yeah, I think that's everything for this week. Lucy's put in the booking link for the 3rd of July, the GP Consultant Network event. I know there's a lot going on at the moment, so if you have got any worries, concerns, questions, please do get in touch with us and we'll be happy to help in any way that we can. Lucy.
Emma, sorry, I'm conscious of time, so we will see back next week. So just to say, Michael and James are attending next week's Practice Weekly briefing to update on LMC work. James and I are also going to NUH this afternoon to meet with Dr. Jonathan Evans, who's the clinical lead for neurology. So we will feed back next week about how that meeting goes. So this is raised on the back of concerns from practices about referring into neurology. James, I can see you've got your camera on now. Did you want to come in or just... No, thumbs up.
No,
we're going to
suddenly
NUH in about 10 minutes.
Yeah.
Yeah.
Yeah. No.
So we'll certainly feedback as well about that next week.
Thank you for sharing all that, Lucy. It's great to be able to show practices what we are doing behind the scenes, because I think sometimes it can feel like from practices we don't always share all the positive things that we're doing. So we are trying to make more of a conscious effort to make sure practices know everything that we are working on. Not everything is a quick overnight fix. They do take time. So thank you for sharing that insight. And as we've said, James and Michael are coming along next week. If anybody's got any burning issues that they want to hear from us about, please let us know in advance so that we can get that information out to you. But have a good week, everyone. Thank you all for joining us, and we will see you next Monday.
Thanks, Emma. See you soon. Bye.